So we had already discussed about the congenital heart disease and how the pulmonary arterial dilatation and plethora will be affected in the left to right side. The another concept of the another part of the other cardiology is the rheumatic heart diseases and congestive cardiac failure because of the LV dilatation. LV dilatation, in turn LA dilatation, it is always the LA pressure increase which will cause the retrograde venous congestion and the pulmonary venous changes that we all see here. So what will happen in the early stages is that pulmonary venous blood flow will be more in the lower lobes. Usually it is always more in the lower lobes. As the LA pressure increases, the pulmonary venous flow increases, the backward flow increases. As more and more backflow increases, the lower lobe vessels will be more, flow will be more when compared to the upper lobe. So slowly what happens is, because of the increased flow, backward flow in the venous circulation, sudden vasoconstriction occurs in the lower lobe because there is more of congestion, venous congestion in the lower lobes. So reflex vasoconstriction causes a increased pulmonary venous flow in the upper lobe. That is what is seen here. There is a reflex vasoconstriction and there is an increased flow in the pulmonary venous flow in the upper lobe, and this is what is called cephalization. This is the early stage of any venous congestion. Even in MS you can see it classically. In the rheumatic MS, usually venous congestion is low, so you will see that vasoconstriction occurs here, and then suddenly there is cephalization. That is called redistribution of the venous vessels in the lungs. As and when the venous congestion still increases, both the lobes will be increased, and as there is still a vasoconstriction, only slowly the blood will start oozing from here, these places, forming the pleural effusion by snapping out the costophrenic angles, that is forming the pleural effusion. Then slowly the fissures will start accumulating the fluids, interlobular fissures, that is called the B lines, Kerley B lines. If they occur in the middle lobes, then it is called Kerley A lines. If these fissure lines are cutting at the cross section, that is, if you are getting a round shadow of the fissural edema, then it is Kerley C lines. What you are seeing in the name of the 3 is, these are all the fissural edemas. Always look for fissural edemas. They will confirm that the patient is having fluid overload or pulmonary edema kind of condition, maybe due to fluid overload, maybe due to venous congestion and all. Then one is the perihilar snuffing, perihilar bronchial snuffing. The bronchial peribronchial edema starts, and it can be seen in the endon as a circular shadow, or it can be seen as a peribronchial coughing and puffing of the blurring of the shadows of the peribronchial vessels because of that is the venous congestion. That is sign of venous congestion. If there is volume overload, pulmonary arteries will be strictly seen as margins. If there is a venous congestion, there is the snuffing, that is venous effusions are seeing, and the peribronchial coughing, and then the peribronchial shadows will become hazy. This hazy area is a sign of venous congestion. As when the congestions will increase, there will be increased distribution, the pulmonary edema will happen, there is increased bronchoscopal markings, and then the pulmonary artery hypertension starts, and then there is a fixed pulmonary artery hypertension with pulmonary artery becoming big and thick. This is the PA shadow becoming big on because of the pulmonary artery hypertension. Then is chronic venous congestion backflow, usually causes the blood to effuse into the lungs, and they form the pulmonary hemosiderosis. These are all the characteristic features of pulmonary venous congestion and pulmonary edema.